Thanks so much for attending our webinar today. Our topic today is estimating the cost of providing foundational public health services. Our presenter today is Dr. C.B. Mamaril, who's a research assistant professor for the Systems for Action National Coordinating Center at the University of Kentucky College of Public Health. So, C.B., you want to take it away?
Thank you, Rick. Can you hear me?
Yes, we got you.
All right. Well, thank you, Rick, for the introduction, and Happy New Year to everyone. And thank you for your time in joining us today. I'm happy to talk about some of the intramural research work that we're doing here at S4A at the University of Kentucky, as led by our director, Dr. Glenn Mays, in particular for this webinar today as it relates to the work that we're doing around estimating the cost of providing foundational public health services. Some of you may already be familiar with this work as we presented some of the preliminary results in a webinar in March of last year, but we're taking this opportunity to present additional results from our analysis using additional data that our colleagues from the University of Washington Public Health Activities and Service Tracking, or FAST study team, has been so generous in sharing with us. So before I start, we want to acknowledge the funding and support of the Robert Wood Johnson Foundation in making this study possible, along with its funding and support for the Systems for Action National Program. We also want to acknowledge the Public Health Activities and Services Tracking FAST study team out of Washington, led by its principal investigator, Betty Beckmar, and their team for their graciousness and generosity in sharing their data and data collection instrument. Obviously, we also want to acknowledge the work of the Public Health Leadership Forum, which was coordinated by Resolve out of Washington, D.C., and I'll talk a little more about that later. We want to thank the research assistance that we received here at UK, particularly those provided by Keith Branham, Lava Timsina, and Merlin Kuzinoff. And we also want to thank the participation in our pilot survey sample by the Kentucky Health Departments Association, that's coordinated by Dr. Georgia Heise, and the Association of Ohio Health Commissioners with the leadership and coordination of Terry Allen. So, you know, much of the impetus towards trying to understand the public health fundamental components and costs stem from the fact that the United States faces mounting pressure to improve population health as medical costs rise while American health status falls further behind that of other developed nations. So the enactment of the Patient Protection Affordable Care Act in 2010 ushered in a series of initiatives to expand health insurance coverage and find improved models for delivering and paying for medical care. Now, much less attention, though, was focused on the nation's public health system, which is charged with preventing disease and injury in the population at large and ensuring the safety of water, food, air, and other conditions necessary for optimal health. Now, of the $3 trillion spent on healthcare services in the U.S. in 2014, less than 3% supported governmental public health activities. So studies have consistently found that U.S. public health system to be highly variable in its capabilities across states and communities, and fragmented with respect to governmental and private sector roles and responsibilities, and constrained by inadequate and unstable financing. So a 2012 Institute of Medicine report identified two fundamental barriers to improving the nation's public health system. The first was a lack of agreement on a core set of public health capabilities that should be present in every U.S. community. And second was a lack of knowledge about the resources required to implement those capabilities. So this IM report concludes that sound policy for improving the nation's public health system can move forward only when there is sufficient understanding and agreement about what the public health system should be able to do and how much it will cost. In that same 2012 IOM report, a couple of recommendations were laid out, including the need to convene an expert panel process to identify the components of a minimum package of public health services and cross-cutting capabilities that should be available in every U.S. community to protect and improve population health. Correspondingly, the report also recommended undertaking and expanding research to estimate the resources required to implement these services and capabilities universally across the U.S. So along those same lines, the report also recommended development and implementation of a national or universal chart of accounts to to be able to track spending and flow of funds that can also be used to generate information needed to estimate the costs of providing these essential services. Now, some of the work that provided a starting template for the work carried out by the Public Health Leadership Forum was informed by notable similar state-level initiatives that were carried out to define and determine the cost of providing their own essential public health package at the state level. So some of the more notable examples include the work out of Washington State with their Foundational Public Health Services, in Ohio with their Public Health Futures Committee, and in Colorado with their effort to cost out their public health services. Now, at the national level, in response to the IOM recommendations, the Robert Wood Johnson Foundation commissioned a national expert panel in 2014, known as the Public Health Leadership Forum, or PHLF for short, and these included representatives from federal, state, and local public health agencies, public health professional associations, universities, public health accrediting bodies, and health policy advisory commissions. So this national work group used available research, practical experience, and expert opinion to distinguish two broad types of responsibilities or actions within the public health system, namely categorical programs and policies and cross-cutting capabilities. So some of the work that to determine, define these foundational public health capabilities has already been well documented and is available online for those who are interested to learn more. But for those who are not as familiar, I'll go over some of the definitions that the national expert panel provided. So starting with those first broad type of responsibilities known as foundational areas. So these are substantive areas of expertise or program-specific activities in all state and local health departments essential to protect the community's health. The second general type of responsibilities are referred to as foundational capabilities, which are cross-cutting skills that need to be present in state and local health departments everywhere for the health system to work anywhere. So these are needed to support the foundational areas and other programs and activities and are key to protecting community health and achieving equitable health outcomes. So when we put these two broad types of responsibilities or actions together within the public health system, we refer to them simply as Foundational Public Health Services, or FPHS. So that when you see this acronym in the slides, you'll know what it is referring to. So this graph provides a good illustration of the FPHS framework, and I'm sure some of you have seen this already. And it shows how these foundational areas and foundational capabilities relate to each other. So if you note, there are 6 foundational capabilities, namely assessment, all hazard preparedness and response, policy development and support, communications, community partnership, and organizational competencies that cut across the 5 foundational areas. And these essentially provide the form of organizational structure, infrastructure, decision support architecture, and collaborative capacity needed to support these foundational areas. Now, something of note, if you notice in the diagram, in this dotted or broken line that cuts across the 5 foundational areas, namely communicable disease control, chronic disease and injury prevention, environmental public health, maternal, child, and family health, and access to and linkage with clinical care. This is referred to as below the line and above the line. So this framework recognizes that public health supply and demand for every community depends heavily on demographic, socioeconomic, environmental, cultural, and epidemiological characteristics that shape health risks and needs. And these vary widely across communities and change over time. So in other words, what may be deemed essential or foundational in one community may not be necessarily so for another. Nevertheless, everything below that line would represent the resources and substantive areas of expertise that should be present for all program-specific activities in all states and local health departments across the country. So in parallel with a definitions work group that was put together by the expert panel work group, or by PHLF, another work group was formed to develop the methodology to estimate the costs of implementing these foundational public health services. The report from that work group is also available online for those who are interested to learn more about that work. Now, this methodology was then pilot tested through 2014-2015 with the help and participation of local health departments from the Kentucky Health Department Association and Association of Ohio Health Commissioners. As we mentioned earlier, analysis for this presentation incorporates additional data from a delivery and cost studies project carried out by the Washington FAST study team. And if I'm not mistaken, this data was collected throughout 2015 with some, I think, work that began in 2014. So with that, just to give an overview of the data collection process, we started off with adapting and modifying a data collection instrument that was developed out of the Washington DAC study. And again, we want to thank the Washington FAST study team for graciously sharing their instrument with us. And prior to data collection, we first asked the respondents to review the Public Health Leadership Forum document that identifies and defines each of these 11 foundational public health service domains. So before they start, filling out the survey or providing information, they first review this document and meet with their respective agencies or their respective teams. And based on their understanding of the documents, we then ask our LHD respondents to fill out the questionnaire that is comprised of 6 general sections. And these are the workforce composition, information on their labor resource use, information on their salary and fringe benefits, information on their total annual non-labor costs across these 11 foundational public health service categories. And we also ask them to provide information on a needs assessment or current attainment scale, which measures or tries to estimate their full attainment projected need relative to their current attainment. So this slide, I'm missing a slide here. Let's see. Anyway, I should have a slide here about the definitions, an example of a definition. Let's see. Anyway, going back to this slide, as we collect detailed data on current resource use and current attainment levels for each element or domain, we then use the information to estimate the expected costs that would be required to fully implement these foundational public health service elements, assuming 100% attainment and also the unmet resource gap, which would be the difference between current costs and expected costs. So in this slide, we have a graph that provides a conceptual representation of that approach. So if you note point A on the curve, to get that information, we ask the question to our local health department respondent, based on your understanding of how each public health foundational capability and foundational area is defined, please provide your global or overall assessment on the following question. So for each foundational category, what is the estimated percentage currently being met by your health department? So by knowing the current costs associated with point A, we use that information to estimate point B and also the resource gap, which is the difference between point A and point B. So this type of data collection already carries the inherent burden associated with complex surveys. And so the idea would be to apply a methodological approach that can be efficiently self-administered to elicit information that can capture estimates that account for variation in cost due to the dynamic nature of public health, supply and demand. So, given the time and resource constraints, we settled upon a pragmatic empirical approach that utilizes simulation modeling to estimate the costs of implementing these foundational public health services by modeling variation associated with the collected cost data, as well with the uncertainty associated with the interpretation of these foundational public health service domain definitions. So this approach involves collecting data on upper bound and lower bound estimates of current resource use for each foundational public health service and each resource category, labor and non-labor, along with the estimates of the most likely resource levels used in their agency. So this information is then used and combined to generate probability distribution of costs, which range which is essentially the range of all possible cost values and the likelihood of their occurrence, as opposed to just getting data that estimates a point estimate of the resource use. We then use model Carlo simulation techniques to estimate both within agency uncertainty and between agency variation in resource use, separate these two components, and then calculate the most likely levels of resource use. We estimate 10,000 iterations of the simulation model using Latin hypercube sampling and assume a program evaluation review technique or PERT distribution for all cost parameters. So this slide provides a visual presentation of the simulation model approach that we use. So if you notice, the probability distributions for total foundation public health service costs at the bottom right of the slide is derived from randomly sampling out of the 22 input cost distributions across the 11 foundational public health service domains. So in summary, the cost estimation methodology produces three sets of cost estimates. One, the costs currently incurred by an agency to implement each foundational public health service element. The expected costs that would be incurred by the agency to implement each foundational public health service at full attainment levels. And lastly, the unmet resource gap that is calculated as the difference between the expected costs and current costs for each FPHS element. So the next few slides will present some of those results, incorporating the additional data so generously provided to us by the Washington FAST study team. And this is data from their study that involved 10 local health departments, and we added that to our pilot survey sample of 9 local health departments from our Kentucky and Ohio pilot surveys. So these 4 graphs represent the probability distributions for each part of the analysis, and this is just for total foundational public health services. So the upper left-hand corner, or the first graph in blue, represents or displays the probability distribution associated with estimated current per capita costs. So the way to interpret it is you have delimiters at the 2.5 percentile and the 97.5 percentile. There is a 95% probability that the mean value for these current per capita costs lies somewhere between $33 per capita and $64 per capita, with the estimated mean to be $48 per capita. The red graph on the right side of it is the probability distribution for our per capita costs for full attainment of providing these foundational public health services. So the estimated mean for this, our simulation model approach showed that it was at $82.43 per capita. Now the neat thing about being able to generate probability distributions for these costs is that you can overlay these graphs to put these probability distributions, or at least the variation associated with this cost, into proper perspective, and also be able to derive the resource gap associated with the difference between the current per capita cost and the expected per capita cost. So at the lower left-hand corner of the slide, you see the graph overlay, and you get to see also a visual representation of the variation associated with the cost for each type, both the current and the expected per capita cost. And we're also able to generate an estimate of the resource gap, which was estimated at around $34 per capita. So this table provides the full results from the full model. And if we consider just the mean values that are reported, that are generated by our simulation model, we see that the estimates of the current resources devoted to foundational public health services totaled $48.14. So that was illustrated by that blue graph you saw in the previous slide. And that would include $18 per capita for foundational capabilities and around $29 for foundational areas. Now, organizational capabilities accounted for the largest share of resources devoted to foundational capabilities, contributing about 53% of these costs. Communication accounted for the smallest share of these resources devoted to foundational capabilities, contributing about 3.4% of these costs. Now, the maternal child health domain accounted for the largest share of resources devoted to foundational areas, contributing nearly 37% of these costs, while the chronic disease and injury prevention domain accounted for the smallest share of resources to foundational areas, contributing about 11% of these costs. Now, moving to the right half of the table, taking a look again at those mean values of the estimates of the expected cost to achieve full attainment of these foundational public health services, you would know that these were about 70% larger than the estimates of current resource use. So looking at the total, expected total of $82 per capita, which was illustrated in the graph in the previous slide, this includes $31 per capita for foundational capabilities and $50 per capita for foundational areas to achieve full attainment of foundational areas. Now, expected cost estimates were more than twice as large as current cost estimates in 4 of these domains, including assessment, emergency preparedness, policy development, and chronic disease and injury prevention. So this estimates imply that reaching full attainment of these foundational public health services in these domains would require more than a 2-fold increase in resources per capita. So again, from the previous slide, if we were to get the difference between the expected cost and current costs, we would have an estimated resource gap around $34.29. So that was also visually presented in the previous slide. Now, in terms of future research or possible analytical opportunities, another feature of our simulation modeling approach is that it allows us to also examine geographic variation of costs and also variation of costs by public health jurisdiction sites as well. So this is something that we're doing in future research. So these are just some examples of these graph overlays. So on the left-hand side, we have these graph overlays of current versus expected costs according to geographic or survey site region. And on the right-hand side would be those graph overlays of the expected versus current versus expected costs according to public health jurisdiction size. So it is important to note that there are several limitations associated with this analysis. The foundational public health service elements are defined using general terms that leave considerable room for interpretation regarding resource requirements. The lower bound and upper bound cost estimates produced by this analysis represent 2.5 and 97.5 percentiles of the cost distribution, and they're there to reflect the uncertainties that are inherent in these definitions. While we do have a diverse cohort of local health departments in our sample, it still represents a limited number of states and communities that may not be fully representative of the nation as a whole. Although we do apply some weighting methodology to account for that. Finally, our cost estimates reflect resources required to implement foundational public health services using existing approaches for organizing and implementing public health services at state and community levels, but does not reflect the economies of scale and scope that may be possible through alternative organizational and implementation strategies. However, one important contribution that the application of these estimates can be used for would be in trying to estimate, resource gap needs in providing these essential services. So, sort of a back of the envelope exercise, if we were to scale these per capita resource gap estimates to a national level, the results would imply that full attainment of these foundational public health services recommendations would require an estimated $34.28 per capita, or around $10.9 billion in additional resources per year. If we were to put it in the context, this would mean increasing state local government public health activity spending by around 16.1% over the levels estimated in the National Health Expenditures Count for 2014. Alternatively, resource gap could be filled by doubling federal government spending on public health activities from the $11 billion estimated in 2014. But what's also notable is that consistent with these estimates, the 2012 IOM report recommended a doubling of the federal government expenditures for public health activities in order to fund a minimum package of public health services. Obviously, there is definitely more work that needs to be done in collecting the necessary data, information towards generating national estimates of these foundation public health services. And I think one of the notable efforts that is undergoing right now, and also with the support of the Robert Johnson Foundation, is this Uniform Chart of Accounts initiative. And there's their website too that you can take a look at. And so these are just some of examples of efforts that are undergoing right now to try to achieve that. So I'll end it here, and I'll address some of the questions later on in the chat box. I do want to turn it back to you, Rick, so that we can also hear from our commentators.
CB, thanks so much. We've got two folks who've generously agreed to provide commentary on today's presentation. Dr. Phil Huang and Dr. Georgia Heise. Dr. Huang is the Medical Director and Health Authority for the Austin/Travis County Health and Human Services Department in Texas. Georgia Heise is the Public Health Director for the Three Rivers District Health Department in Kentucky, is co-director of the Kentucky Population Health Institute, and is also the immediate past president of the National Association of County and City Health Officials. Philip, would you like to start us off?
Sure. Well, it's an honor to be here. I think that really seeing this presentation shows great work that has been done with this very important and useful work for all of us in public health. I guess the initial perspective I'm going to be giving is how it fits in with some of the Robert Wood Johnson Systems for Action research sort of activities. And this particular research initiative is really trying to look at evidence to achieve alignment, collaboration, and synergy across the delivery and financing systems. And we chose these three areas specifically for medical care, public health, and social and community services. And really trying to look at those three areas, document, what is our investment, or what should be the recommended investments in those different areas. What is the results and outcomes that one gets with the various investments in those three areas. Because, as we know, so much of our resources go into the medical treatment piece of this, very little for public health. And then the social and community services, we know the social determinants of health, how important those are to health. But, what is that right mix and the relative contributions and results that we get by investing in those three areas. So I think this work really provides a lot of important information for particularly that public health piece. As a person practicing public health at a local health department, and I also was at the state health department, these issues that have been brought up are are the key issues we always deal with. I think we've had some good examples of how this can be used in the past. CDC's best practices in tobacco control that for the first time gave sort of recommended per capita figures for what each community should have invested to achieve tobacco control for a comprehensive tobacco control program, were really useful for us at the state and local levels to give just sort of that ballpark of what it would take. Because before that, it was just there was no reference point. No point to really say, here's sort of where we're shooting for, here's where we're under or over. And so again, this work fits in very well with that, as well as building on what are the core functions of public health, and then also what should those funding pieces be for each one of those. But it's a very difficult issue, and I think the methods that were presented here are as good as they can get. They're very thoughtful, seem to be comprehensive. But, as it's been pointed out, there's a lot of limitations with it. When you look at the the variation between the lower and upper, limits, 2.5% to 97.5%, the cost distribution. And the data, making those calculations from what local health departments are currently investing in these various things, and then saying then what is the actual need or optimal level. I mean, there's a lot of fuzziness in this in the data. But what's good? I mean, again, I think it's a very thoughtful and probably the best application of the best methodologies that can be applied to this. So it does give us this ballpark. It's not an exact science, but a real good ballpark for shooting for and for comparing, where we are now, and it can be applied to whatever the state, federal, or local levels to see again what the gaps are. What's been surprising to me sometimes with this, from a policy standpoint and application, is a lot of the decision makers don't look in the black box that much, and take the results of some of these. They take it very seriously and look at this. It applies when we're competing for funds for public safety. There's some study that the police union says we need this many officers or this many population. They sort of take it at face value and say, oh, we need more officers. And sometimes that same sort of thing happens that I've seen with some of the public health type of things. And so I think it's be very important for us to will help us from policy standpoint. The one thing that I think is missing, or that is that we're talking about the cost and what the core functions are, but we're not talking necessarily about the results that you get for those investments. That is something, part of the argument that I think will need to, again, a lot of people, it's surprising how many policymakers don't ask some of those questions. But I do think to be able to quantitate or try to get some assessment of what we get for this investment is going to be a question that comes up down the road. But again, this effort is very helpful, certainly for me at a practicing level at the local health department. I think from the perspective of Robert Wood Johnson System for Action research program, this fits in very well. We're trying to, with that effort, get the cross-cutting, how these interact also with those other sectors, the medical care and social and community services. So that's the other piece of this, but I think this will help greatly with that. So I think those are my comments.
Dr. Huang, thanks so much. Dr. Heise, would you like to provide some commentary?
Sure. I'm happy to be able to talk about this subject. It's one of my current favorites. And like Phil said, it's very fuzzy, but I like fuzzy. We in Kentucky really, really appreciated the opportunity to be a part of the pilot study. 6 of the health departments were in Kentucky. And those 6 actually moved on after we used the template and started working with CB and his gang at UK and did some work of our own. And we took a group of health departments, representative of each of the different kinds of health departments that we have in Kentucky, and looked at the foundational, we call them capabilities. I realize there's areas, and the areas plus the capabilities are the services, but we, for simplistic reasons, went with calling them capabilities because we wanted to be able to tie them in this way. Health departments are charged with delivering the 10 essential services. You must have the foundational capabilities in place to do that, and along comes accreditation as the stamp of approval that you are getting this job done. So we wanted to overcome a lot of arguments out there related to what is this foundational capability stuff. It's just the latest and greatest in what, public health lingo is going on. And we wanted to be able to tie those things together to, if we could, offset some issue. We've had a lot of folks say, don't get into our funding. It's bad as it is. If you start messing with it, it'll get worse or go away completely. We had a lot of that to contend with. And, in fact, when I've been in other states and talked to others health departments about what's going on in their areas, there are some people who are really, really against foundational capabilities. I think it's because they're afraid. We've all in public health been through a lot of pain in terms of lack of appreciation for the work that could be accomplished if we could ever, get it together and get moving forward with it. CB pointed out the United States is behind the other countries in terms of our outcomes, life expectancy, and so on and so forth. And within the United States, Kentucky is 44th of the 50 states, so we're really at the bottom of the barrel. So we looked at the foundational capabilities, compared them with the statutes in Kentucky of what health departments are required to do by law. Surprisingly, they lined up pretty well. Then we looked at, in our individual different sizes of health departments, how many people would it take to do these services. So this is a little bit of a twist on the information that CB collected and also analyzed. So we started with, if we're going to do this work, it's required by law, how many employees does it take to do it? The information that CB did collect allowed us to have a big database of money that was spent, what percent of the population or what percent of the services were accomplished and that kind of thing. So it was an excellent database. We, after much work, determined that we needed 2.5 FTEs. Now, that's not people, that's that many hours of work. 2.5 FTEs per every 12,500 of population to accomplish the services as they are laid out in Kentucky. And as everybody has said, that is a limitation. Not everybody agrees what is a foundational area and or capability. However, and how we're working it in Kentucky, it looks like 2.5 FTEs for every 12,500, and we have some counties that are that small, and that's why we chose that number to be a starting point. And then we went all the way up to our largest, and of our 4.4 million people in Kentucky, across the state, they are extremely different in terms of the resources they have, the number of employees they have to utilize those resources. So we had a big range of what was going on. But if we looked at everybody's salary, which we did, and all the actual monies that we spent, the same fiscal year data that CBE used, we looked at how much money was spent on our indirect costs, and we came up with an actual number of $116+ million that it would cost to pay employees and their overhead to do the foundational capabilities in Kentucky. So with that data, and it does actually falls in the low end per capita of CB's data, so we went at it from a kind of starting from scratch standpoint of not looking at the services in terms of this much money was spent in this cost center and this much money was spent in that cost center, because that's kind of what we had done with CB. But we went a different direction to say, okay, say we are going to deliver these services 100%, what would it cost? And that's how we came upon, let's figure out our most expensive thing we need here, and that's our employees. Obviously, cost of employees is not, like any of this, is not stable. It goes up every year. So that's something we have to keep in mind. We are moving forward. The health department directors are our association, so all of us, not just the ones that participated in this study, but all of us, to talk to our legislators about this is how we need to be funded. If you want these things that are required by law to happen, this is the money it takes to do it. We have a statewide Board of Health meeting actually tomorrow that was going to be broadcast live across the state to talk to our boards of health about this platform, being our legislative platform. It's already been adopted by our Kentucky Health Department Association and our Kentucky Public Health Association. So we are moving forward, not that we aren't meeting some areas that are very concerned with this, and as you might guess, it is those that are, like CB referenced earlier, above the line, programs that feel like they're being left out. So we're very careful to talk about WIC, HANDS, that's a home visiting for prenatal and small child program. We're very careful to discuss the difference between those programs. While they're very important, they are not statutorily required, and they have their own funding source separate from the sources that are provided or not provided for our statutorily required services. Of the $116 million, that big figure that we came with, which is, I know compared to other states, is going to be very small, a lot of states anyway, we found that most of that is not funded. So our health departments in Kentucky are funded to do a lot of things. Public health is not one of them. So that is a problem. So that's another thing that we are trying to talk to our legislators about. And as you might imagine, not only do we want to get across this message, in order to get this message across, we are still where we have been for 50 years or more. What is public health? Because our legislators, like everybody else in the United States that does not work in public health, and some of those who do, are quick to jump to public health is medical care, and health departments provide that to poor people, and if we take care of that, we're good to go, and there you have it. So we have to start there, defining public health. As much as I hate that we get to do that every day over and over, we have to start there, and then we have to move to here's how public health can be provided, can be funded like this, and these are the things that we can do. And then we've also, in addition to this study that we bring forth as, work that's been done, we also reference another study from UK, the longitudinal study related to comprehensive public health systems, and we can tie that to longer life expectancy. So the statement we are trying to make is where a comprehensive public health system is in place, which you have to have the foundational capabilities to do that, you'll have longer life expectancy. So we are probably taking lots of latitude there, but if we don't go for the golden ring, I'm afraid of what's going to happen to us. We must define public health, what it is, and that it needs its own funding source, not just the leftovers from other programs, which is what we typically get. So I'll leave it at that. Thank you.
Georgia, thanks so much. Looks like we have time for some questions. CB, we've got a couple questions teed up already. The first one is from JP Leader. JP asks, what proportion of costs were you assuming towards staffing versus other types of expenses?
Thank you, Rick. I just want to, before I answer it, I go through the question. I see it also on my slide. I just want to thank Dr. Huang and Dr. Heise for their comments, and just comment a little on what they've mentioned, really about a lot of the fuzziness or uncertainty with these, you could call them first-generation estimates, and a lot of that, of course, stems from the way that these elements are defined, and they're still relatively broad and not that specific, because you're also trying to avoid a situation where, again, what was mentioned, what might be foundational or essential in one community or region may not be necessarily so for another. And so I think what I would like to take from that, also from the comments of George, is really in order to sort of to generate, I guess, more reliable estimates in the future, you do need data and information to be collected, and we found out in the past year or so from just trying to collect data that you also really need a lot of buy-in from both state and local levels, and we got that from Kentucky and from the other states who participated. And I think moving forward, particularly with the effort that's being done with initiative with the National Chart of Accounts or Uniform Chart of Accounts, there's really a lot of work that needs to be done in order to convince more state local governments to buy into this framework, and in order to be able to generate the needed information. So hopefully we can collaborate more in the future too with Texas and here in Kentucky too as well, with state, local, health agencies around the country too as well. And so I want to thank again Dr. Huang and Dr. Heise for their comments. So great questions, JP. I would have to go back to the raw data, but from what I can remember, staffing or labor costs represented about 60 to 70% of the total cost of providing these foundational public health services. JP also asked the question, how confident are you that MCH excluded WIC's clinical side of activities? And again, that speaks again to the limitation of the approach, because we give these definitions as prepared by the National Expert Consensus Panel to these respondents, but we don't provide them guidance of what to include and what not to include. We rely on their best interpretation of these definitions, and hence the use of a model simulation approach, because there's going to be variation associated with the way they interpret these definitions and what they would include or not include. So I can't say really how to account for that, unfortunately, and that's also been sort of an area, some of the areas of contention also in defining these domains, particularly also when it comes to the MCH, especially since it makes up a big part of the cost. Simone asks, it looks like your average cost of foundation public health services is about $48 per count. Is very close to the total cost per count expenditures of all LHDs, as reported in the 2013 Nature profile, which was about $57 per capita. So I wonder if your data is overstating the true cost of providing FPH. Again, I can't really say with confidence, because we rely on the way our respondents understand these definitions. And so again, there's going to be variation in what they would consider or would count as foundational or essential compared to local health agencies or public health agencies in other regions as well. But it is a great question and something that needs to be looked at also as well. Carl mentions, are there any efforts to cost out the return of investment of current implementation in terms of morbidity and mortality and the ROI of full implementation? We can't ask for more without building the business case. That's an excellent question, Carl, and that's something that we at S4A, as part of our intramural research, are looking forward to doing, where we both use our FPHS cost estimates along with linking that along with our National Longitudinal Survey of Public Health Systems data, and linking that as well with mortality and morbidity data too as well, to examine those relationships. Susan says the handout suggests the questionnaire was divided into 6 sections, but only 5 presented. I apologize. That was a typographical error. There should have been 5 sections. Are data available for each question item? For instance, workforce composition, yes, it would be shown in the questionnaire, the raw data that we have, because we apply a wage scale that accounts for both occupational category and job experience, along with a wage rate associated with that. So that information would also be there too as well. Thanks, JP, for your comment. It's really been a challenging project for the initiative that you guys are undertaking right now. That's true. Rick, I turn it back to you. I don't see any more questions, but if there are any more questions, feel free to get in touch with us directly here at S4A or with me or with our team here. We're more than happy to discuss with you.
All right, CB, thanks so much. I guess I was disconnected briefly, so I just came back in on the line here. So I'm assuming you got all the questions, correct?
Yes. Thank you so much for helping with the moderation.
Great. Wonderful. So we've got upcoming webinars. We've got one scheduled next week, and then one in February 8th. So one next week is interorganizational collaboration in local public health systems, and the one in February is understanding rural-urban differences and the implementation of public health activities. So if you'd like to attend these, or we also have an archive of our previous webinars. If you'd like to see those on the top of the screen there. But thanks for participating in today's webinar. If you have any questions, please feel free to contact Ann Kelly at the email address on your screen.
Thank you, Rick.